Hello, and welcome to Leading Age Florida's regulatory series. My name is Carol Berkowitz, and I am the Senior Director of Regulatory and Legal Affairs at Leading Age Florida. Today we are presenting you with the HIV/AIDS Review and Update program. At this time, I have the pleasure of introducing Marilyn Maud, our speaker. Marilyn received her nursing degree from Boston University and her master's degree from Morehead State University in Kentucky. Marilyn has taught in the undergraduate nursing program at Morehead State University, and she has also taught at Florida State University. She worked for 20 years at the Florida Department of Health. Her experiences at the department includes the development of the AIDS program, as well as working with the Quality Improvement Office and serving as a statewide nursing director for public health nursing. She has also worked as a nurse consultant in the Leon County School Health Program, as well as the Quality Improvement Office at the Leon County Health Department. And so with no further ado, let's get started.
Good morning, good afternoon, good evening, at whatever time you're viewing this production. I'm glad you could join me. I'm going to talk a little bit about, or I'd say a whole lot about HIV/AIDS. It's a review for some of you, as well as an update for most of you. And I've done it this year, 2012. So we'll proceed to just talk a minute about the objectives, where I'm going to talk about transmission of HIV infection, describe risk behaviors for HIV/AIDS, talk about HIV testing, as well as the background and trends in HIV/AIDS in the United States and Florida. Going to talk a little bit about treatments that are available for people and the resources for current information that you may like to go to for further information. So we'll start off with the basic, what is HIV? It's an acronym for Human Immunodeficiency Virus. And defining those parts of that phrase, human means the virus can only infect humans. Immunodeficiency means the body doesn't work properly with its immune system. And virus is one that can't reproduce by itself. It must take over the machinery of the human cell. This is a shot of the HIV virus, which took many years to identify, and then to actually have a photo. To some of us, it's very helpful to see what it looks like. But I would not try to describe it. So what is AIDS? AIDS is acquired immune deficiency syndrome. It's the most serious stage of HIV infection, and that happens because the person's immune system is destroyed. So A stands for acquired. It means it's passed from one person to another. Immune is the body's defense system against disease. Deficiency is a breakdown of the body's system, and syndrome is a combination of symptoms and diseases. So the virus, HIV, may lead to AIDS. The HIV attacks and destroys specific white blood cells, and those are the ones that are CD4 and T cells of the immune system. You've probably heard those terms, and those are the cells that are crucial to fight infections and disease. You'll also hear that when a patient's being tested, one of those tests will be his CD4, and that measures how well the immune system works. A little bit of background history about HIV/AIDS. It started out in 1979 through 1981, when rare types of pneumonia cancer were reported by doctors in both LA and New York. And these were among male patients who had sex with other men. And there were conditions not usually found in people who had healthy immune systems. In 1982, public health officials began to use the term acquired immunodeficiency syndrome. And this is when we were seeing opportunistic infections, Kaposi sarcoma, pneumocystis pneumonia. And this is when we actually started nationwide the surveillance of AIDS cases. In 1983, the scientists discovered the virus that caused AIDS and named it HTLV3, and then later changed it to HIV, which is much easier. And where did this HIV come from? It took many years and many teams of researchers to identify the origin of HIV and lots of false starts. Finally, they reported that they had discovered the origins of HIV-1. And it came about through a subspecies of chimpanzees native to West Equatorial Africa that had been identified as the original source of the virus. The researchers believe that HIV-1 was introduced into the human population when hunters became exposed to infected blood. I'm going to talk a little bit about opportunistic infections. That's a term you'll hear, you'll see, and it means those infections that are more frequent or more severe because of immunosuppression, HIV-infected persons. They're the principal cause of morbidity and mortality, and that morbidity and mortality is coming down because of the development of combination antiretroviral therapy, which you will see and hear as ART. Some of the opportunistic infections include pneumocystis pneumonia, or PCP, toxoplasmic encephalitis, or TE, cryptosporidiosis, and you'll hear crypto, microsporidiosis, you'll hear micro. And as you can see, we do abbreviate those names because they are kind of tricky sometimes. And those other opportunistic infections are some that are perhaps less commonly identified as HIV. In the early 1990s, the use of chemoprophylaxis, immunization, and better strategies for managing acute opportunistic infections contributed to improved quality of life and improved survival. But what really had the most influence was the widespread use of ART in reducing opportunistic infection-related mortality in HIV-infected patients. Some of the reasons that opportunistic infections are still out there and causing so many illnesses and deaths are related to a variety of factors, and often it's more than one. Many people are unaware of their HIV infection, and they only go for medical care when there's an opportunistic infection that becomes the initial indicator of the disease. Some folks are aware of their HIV infection, but they don't take the antiretroviral therapy, and that may be related to psychosocial or economic factors. Some are prescribed ART, but they don't get enough of a virological, immunological response, and that's because of factors related to mostly adherence. They can be quite difficult for folks to continue with the regimen, partly because there are multiple medicines and they have to be taken frequently throughout the day. Hospitalizations and deaths have decreased since ART, but as I said, the opportunistic infections are still remain a leading cause of morbidity, mortality, HIV-infected persons. Infection with HIV has been the sole common factor shared by AIDS cases throughout the world. And those AIDS cases develop with men who have sex with men, transfusion recipients, persons with hemophilia, sex partners of infected persons, children born to infected women, and occupationally exposed healthcare workers. So if someone was diagnosed with HIV infection, then they've had from 45 areas, and this is 40 states and U.S. dependent areas that have had confidential name-based HIV infection reporting. And that's something that was worked on a long time to be able to come to that solution to identify folks infected with HIV prior to being diagnosed with AIDS. Those areas that I mentioned as dependent are our territories: American Samoa, Guam, Northern Mariana Islands, Puerto Rico, and the U.S. Virgin Islands. After more than 28 years of scientific research, it's concluded that if a person is exposed to HIV through sexual contact or injecting drug use, they may become infected with HIV. If they become infected, all of these folks will eventually develop AIDS. Looking at AIDS and the cumulative number estimated through 2009, those 40 states represent 75% of the AIDS diagnosis in the 50 states plus DC. There's over 1 million cumulative estimated number of AIDS diagnoses through 2009 in the United States, and of those over 1 million diagnosed in the 50 states and DC, and then the 34,000 diagnosed in dependent areas. In the 50 states and DC, it's over 800,000 cumulative AIDS diagnoses among adult and adolescent males. And then the rest of the numbers are among adult adolescent females, and then among children under age 13 years. And we'll talk a little bit about how come in a moment. Two terms you really need to know when we're talking about AIDS or infections. Incidence is the number of new HIV infections in a specific population during a specific period of time, whereas prevalence is the number of people living with HIV infection in a given year. In your reading or your studying, you'll hear and see a lot about prevalence and incidence, and that's why those terms have to be understood. Prevalence then, at the end of 2008, an estimated 1 million people aged 13 and older living with HIV infection in the United States. Of those, 20% estimated has undiagnosed HIV infection. So incidence, I said, is the number of new HIV infections occur during a year. CDC estimates that approximately 50,000 people are newly infected with HIV each year in the United States. CDC stands for Centers for Disease Control and is one of our bureaus, agencies that has worked for many years with HIV and AIDS. In 2009, the most recent year that data are available, there are estimated 48,000 plus new HIV infections, with 61% of those new infections occurring in gay and bisexual men. Black African American men and women are strongly affected, and they're estimated to have an HIV incidence rate 7 times as high as the incident rate among whites. All of this, as you may understand, interrelates with how we test folks, how we identify infections, and then how we proceed with their care. One of the things that occurs with HIV is something called co-infection. That means that infections with more than one disease at the time. Some of these commonly seen in people infected with HIV include hepatitis B virus, hepatitis C virus, and tuberculosis. Hepatitis B virus is spread through blood, semen, or other body fluid of an HBV-infected person. The main way people get hepatitis B virus is unprotected sex or sharing drug needles. Hepatitis C virus is spread through the blood of a person infected with hepatitis C, and again, sharing drug needles with a person. HCV is the main way to get HCV. It also may be transmitted during unprotected sex. Tuberculosis is a disease caused by Mycobacterium tuberculosis. It's spread through the air and usually attacks the lungs. There are two forms, latent and active. Latent is inactive, can't spread to others. But the difficulty is that without treatment, it may advance to tuberculosis. Active TB occurs when TB bacteria multiply and the person becomes sick, and then it can be spread to other people. In a person infected with HIV, tuberculosis is considered an AIDS-defining condition. Now we're going to talk a bit about HIV testing. Most commonly used HIV tests detect HIV antibodies, and those are the substances that are created in the body in response to becoming infected with HIV. There are tests that look for HIV's genetic material or proteins directly, and they may also be used to find out if someone has been infected with HIV. It can take some time for the immune system to produce enough antibodies for the antibody test to detect them. And this is called a window period, and that's between the infection with HIV and the ability to detect it with antibody tests. During this time, the HIV viral load, likelihood of transmitting the virus to sex or needle-sharing partners may be very high. Most people will develop those antibodies that we can see by the most commonly used test within 2 to 8 weeks. 97% of people will develop detectable antibodies in the first 3 months. You'll see why this is important in just a minute. And some folks take much longer to develop those antibodies. A follow-up test more than 3 months after the last potential exposure to HIV needs to be considered. In extremely rare cases, it could take up to 6 months to develop antibodies to HIV. So those are the parameters of HIV testing. So the conventional HIV tests are sent to the laboratory. It may take a week or 2 for test results. But there are also rapid HIV tests, which give results in 20 minutes. A positive HIV test result means they may be infected with HIV. All positive HIV test results must be verified by a second or confirmatory HIV test. Now, CDC recommends routine HIV screening in healthcare settings using what's called an opt-out approach. And this is recommended because it's believed it will increase the number of patients being screened for HIV infection. It will detect HIV infection earlier and link patients with unrecognized HIV infection to clinical and prevention services. CDC defines opt-out screening as performing HIV screening after notifying patients that the test will be performed and the patient may elect to decline or defer testing. Assent is inferred unless the patient declines testing. So they have to say no, they don't want it, or otherwise it will be performed. For many years now, many healthcare providers have adopted the policy of universal testing of pregnant women with patient notification, what I just mentioned as opt-out screening, and the elimination of requirements for extensive pre-test counseling and for explicit written contests for HIV testing. This adoption of the policy has led to a great number of increase in prenatal screenings and a dramatic 95% decline in perinatally acquired AIDS cases. And this has been just critical in our newborns. HIV testing certainly has become easier, more accessible, and less invasive in recent years. Technology for HIV testing has expanded, and specimens can be collected by less invasive than venipuncture, oral fluid, urine, and finger stick blood. Rapid HIV testing allows clients to receive results the same day. This is particularly important in medical emergencies, like particularly in the ER or when there's surgery required, and in settings where clients tend not to return for HIV test results, which is pretty common in some STD, sexually transmitted disease clinics. The rapid HIV test can be provided where the provider can tell the patient the result is negative, they're not infected. But there is still the caution that if they have had a recent or within 3 months known or possible exposure to HIV, then they can't say definitively that their test is negative. Retesting is recommended for people who have had a possible exposure within 3 months because, as I mentioned earlier, you need time for those antibodies to develop, and they may be right in the middle of that window of opportunity. Rapid HIV tests, when there's a preliminary positive screening test result, then further testing is always required. We have to explain to clients that a confirmatory test can be done that day, but they won't have the results right away. For clients with a rapid HIV test result, you must explain the meaning of the reactive test result in simple terms. Some of the terminology with HIV/AIDS is very complicated, and it needs to be made so understandable for most folks. You have to emphasize the importance of confirmatory testing, that that's the only way we'll really know that the patient is infected or is not. We need to schedule a return visit for the confirmatory test results and remind them that they must take precautions to avoid possibility of transmitting infection to others while they're awaiting the results of the confirmatory testing. Moving on to AIDS. AIDS is a late stage of HIV infection, and this is when the immune system is really damaged and can't fight diseases and cancers. Before the development of certain medicines that we have now, the ART, people could, with HIV, progress to AIDS in a very few years. Currently, people can live much longer, even decades, with HIV before they develop AIDS. And that's because of the ART combinations of medicines that were started to be used in the mid-1990s. Okay, how about HIV transmission? It's been isolated from infected individuals in blood, seminal fluid, pre-ejaculate, vaginal secretions, urine, cerebrospinal fluid, saliva, tears, and breast milk. What we need to make sure is clear for folks: there have been no cases of HIV infection traced to saliva or tears. So then, how is AIDS contracted? First of all, and one of the largest reasons, is through sexual contact. This is vaginal, oral, anal. Does not include casual kissing unless they're open mouth sores. Sharing hypodermic needles through IV drug use, mother to infant transmission. This can happen while the mother's carrying the baby, during birth, or through breastfeeding after birth. And less commonly through transfusions of infected blood or blood clotting factors. In 1985, the donor blood screening program began, and this was to enable us to say the blood transfusion is safe. Lots of testing, lots of advances were made, and I would like to make the point also that when you donate blood, you cannot get HIV or AIDS. So as I said earlier, HIV is spread through blood, semen, genital fluids, or breast milk. People with HIV can spread disease at any stage of HIV infection. And to again emphasize, the most common way people are infected is unprotected sex with persons with HIV infection and sharing drug needles or syringes with a person with HIV infection. I said before, women who are infected with HIV can transmit the virus to the baby during pregnancy, childbirth, or breastfeeding. Okay, how about how HIV/AIDS is not transmitted? There was a lot of flurry early on in the 80s about all kinds of ways that they thought people with HIV or AIDS could spread it to the public. So it's clearly been identified during that time that shaking hands, sitting next to someone, hugging is not going to transmit HIV/AIDS. Also, objects like toilet seats, doorknobs, and telephones. There was a flurry in Florida for a while about being bitten or stung by insects. Absolutely not true, absolutely proved not credible. Donating blood, as I said, cannot transmit HIV. And just working or being around someone with HIV will not spread HIV/AIDS. So then, who are in the high-risk transmission categories? Male-to-male sexual contact, and you'll see MSM, males who have sex with males. Injecting drug users, IDU. Males who have sex with males who inject drugs, you just double your opportunity for infection. Perinatal transmission, occupational, which is minimal, blood products, and transplants, which at this point in time is negligible, but has been occurred way in the past. Okay, HIV in the U.S. In 2010, there was an estimated 48,000 adults and adolescents newly diagnosed with HIV infection. 79% of those diagnoses were among males and 21% among females. The good thing is that the number of diagnoses of HIV infection has remained stable from 2007 to 2010. Again, the percentage of diagnoses of HIV infection among adults and adolescents exposed through male-to-male sexual contact increased 55% to 61%. And then when you add in injection drug use, then and heterosexual contact, it's relatively stable. Remaining diagnoses of HIV infection were attributed hemophilia or the receipt of blood or blood products, perinatal exposure, and then there's a category of persons without an identified risk factor. In 2010, we had 46 states who used long-term confidential name-based HIV infection reporting. So there's a list kept, and 77% of those infections were attributed to male-to-male sexual contact, 7% to injection drug use. There's a long informational survey that's used with patients to identify exactly, if they possibly can, where were they exposed to HIV. I'm going to talk now about MSM, men who have sex with men, and we're talking about gay, bisexual men. And they represent approximately 2% of the U.S. population. Yet this population from the beginning in the United States has been most severely affected by HIV. In 2006, 53% of all new HIV infections in the United States were among males who have sex with men. Again, with a history of injection drug use, there's an additional 4% of new infections, so that at the end of 2006, more than half of all people living with HIV in the United States were either males who have sex with males or males who have sex with males and IV drug use. In the 2010 adult and adolescents diagnosed with HIV infection in those states who have had long-term confidential name-based IV infection, and Florida is one of those. The final tally of percentages of where is HIV infection, during that time 45% were black or African American, 29% white, 22% Hispanic, Latino, which is on the rise, 2% Asian, and 1% multiple races. Among all males who have sex with males, whites account for nearly half, or 46% of new infections. The largest number of new infections occurred in those men 30 to 39 years of age, followed by those men 40 to 49 years of age. In 2006, more new HIV infections are young black males who have sex with males, ages 13 to 29, than any other racial ethnic age group of males who have sex with males. So the number of new infections are nearly twice that of those who are young and white, and more than 2 times that of the young Hispanic Latino men. In 2006, the largest number of new infections occurred in the youngest age group, although, as I said, there were a new number of HIV infections with older men. Recent study that CDC has done found that in 2008, 1 in 5 males who have sex with males in 21 major cities are infected with HIV. Half were unaware of their infection. Other racial groups have high numbers of HIV infections, And the studies continue around the states, through CDC and through the states themselves. In 2007, males who have sex with males were 44 to 86 times as likely to be diagnosed with HIV compared with other men, 40 to 77 times as likely as women. From 2005 to 2008, the estimated diagnosis of HIV infection increased among males who have sex with male, likely due to a combination of factors. One, increase in new infections, but also increased testing, also earlier diagnosis of infection, and then there's some uncertainty in some of these statistical models of where people are plugged in. Again, in 2008, estimated 17 plus almost 18,000 men were diagnosed with AIDS. And of these, by the end of 2007, estimated over almost 300,000 with an AIDS diagnosis had died in the U.S. in the 5 dependent areas. So sexual risk accounts for most HIV infections in males who have sex with males. The practice of not using a condom during anal sex with someone other than a primary HIV-negative partner continues to be a threat to the health of males who have sex with men. Alcohol and illicit drug also contributes to increased risk, of course, because again they increase the likelihood of risky sexual behavior. Many men are unaware of their HIV infection, especially males of color and young males. A recent study found among urban men who have sex with males in 21 cities were not aware of their infection, and over half had not been tested in the previous 12 months. Some of the reasons that young males who have sex with males may not be aware of their status is they may have been infected more recently than when they were tested, they may underestimate their personal risk, may have had fewer opportunities to get tested, or may believe the HIV treatment minimized the threat of HIV. Centers for Disease Control recommends that all males who have sex with males get tested for HIV once a year, or more often if they are at higher risk. Those at higher risk means people who have multiple or anonymous sex partners or use drugs during sex. Some of the reasons that males who have sex with males may not pay attention to being tested or don't want to share that information with folks is stigma and homophobia, of course. And that means it can prevent them from accessing HIV prevention and care. Sometimes when folks identify as males who have sex with males, certainly their family community support may be isolating. Cultural barriers that inhibit integration into social networks may also be created. And then there are barriers to HIV prevention services, particularly for males who have sex with males from racial or ethnic minority communities. And in those communities, we often see racism, poverty, and lack of access to health care. And one last item in regards to men who have sex with men is about the 2009 CDC budget for HIV/AIDS. 43% of the CDC's Division of HIV/AIDS Prevention's budget was targeted towards men who have sex with men and men who have sex with men and are IV drug users in 2009. CDC, since the beginning, has provided funding for state and local health departments and community-based organizations to support HIV prevention services for males who have sex with males in a variety of settings, including those men of color and young transgender persons of color. Now I'll talk a little bit about healthcare personnel. And beginning in December 2001, there were 57 documented cases of occupational HIV transmission to healthcare workers in the U.S. And as you might guess, that really concerned many folks in the healthcare profession. And this occupational transmission of HIV is reported in the CDC HIV surveillance report. And those categories include hemophilia, blood transfusion, perinatal exposure, risk factors not reported or not identified, which happened a great deal in the very beginning of identification of HIV and AIDS. The important point from all this is there have been no confirmed cases reported among healthcare workers since 1999. And so what's influenced some of that not being transmitted among healthcare workers is, of course, our infection control universal precautions be used at all times. We must assume that blood and all other body fluids are potentially infectious. So what does that mean? We have to use barriers like gloves. If we anticipate a splash, then you should use goggles when you're working with blood or body fluids. Immediately, your hands must be washed and any other skin surfaces after there's been contact with blood or body fluids. Supplies and equipment must be disinfected, must be careful handling and disposing of sharp instruments during and after use. CDC developed recommendations for healthcare personnel who had occupational exposure to blood and other body fluids that might contain HIV. And there was an article in the Morbidity Mortality Weekly Report of September 30, 2005 on how to manage occupational exposures. Something's called PEP, post-exposure prophylaxis, is what was reported to be indicated for an exposure, which has gone on since that time. The follow-up of exposed workers to prove adherence to PEP is critical, as well as monitoring for adverse events, including if they convert to positive. And occupational exposures since the beginning have been regarded as urgent medical concerns. For those folks, healthcare workers, again, seeking care less than 72 hours after non-occupational exposure to blood, genital excretions, or other potentially infectious body fluids of a person known to be HIV infected, when exposure represents substantial risk for transmission, then a course of highly active antiretroviral therapy for 28 days is recommended. As you can see, it's called HART. Again, we have these words that are long, and we like to use the abbreviations, the acronyms. As soon as possible, antiretroviral medication should be initiated, and that's one of the critical pieces. For people seeking care less than 72 hours after non-occupational exposure, where exposure represents a substantial risk for transmission, if the source were HIV infected, no recommendations are made for the use of PEP. People with exposure histories that represent no substantial risk for HIV transmission or who seek care after 72 hours after exposure, again, does not recommend the use of PEP. Clinicians, again, look at each case on a case-by-case basis and can prescribe PEP for exposures even if the person seeks care after more than 72 hours after exposure. The Morbidity and Mortality Weekly Report recommendation from January 2005 speaks to the antiretroviral post-exposure prophylaxis. And these recommendations come from the U.S. Department of Health and Human Services. So PrEP is short for pre-exposure prophylaxis. May be part of comprehensive HIV prevention services where negative people who are at risk take antiretroviral medication daily to try and lower their chances of becoming HIV positive. To date, it's been shown to be effective in men who have sex with men, heterosexual men and women. So this study, again, is looking at those kinds of factors and is not available to the public at this point. They're also looking at whether it's safe and effective in reducing HIV infection among injection drug users. Okay, HIV/AIDS in women. In 2009, there were an estimated 11,000 plus new HIV infections among women. And so that year, women comprised 51% of the US population, but only 23% of those newly infected with HIV. Most people who are diagnosed with HIV infections among adult and adolescent females are attributed to heterosexual contact, and 14% were attributed to injection drug use. Of the total number of new infections in US women in 2009, 57% occurred in blacks, 21% in whites, and 16% in Hispanic Latinas. For women living with HIV infection, most common method of transmission were high-risk heterosexual contact and injection drug use. Deaths attributed to HIV among women of color are disproportionately high, and from 2000 to 2007, HIV infection was among the top 10 leading causes of death for black females and Hispanic Latina females. Some women become infected because they don't know that a male partner has risk factors HIV infection, or they don't know about HIV and they have a very low perception of their risk. Relationship dynamics also play a big role. Some women may not insist on condom use because of the fear their partner will physically abuse them or even leave them if they insist on use. Both unprotected vaginal and anal sex pose a risk for HIV transmission, and women, unprotected anal sex presents an even greater risk for HIV transmission than for unprotected vaginal sex. Women who have experienced sexual abuse may be more likely than women with no abuse history to use drugs, to have difficulty in refusing unwanted sex, to exchange sex for drugs, or engage in high-risk sexual activities. Injection drug and other substance use increase HIV risk because they're sharing injection equipment contaminated with HIV, or engaged in high-risk behaviors such as unprotected sex when under the influence of drugs or alcohol, or both. The presence of some STD, sexually transmitted diseases, greatly increases the likelihood of acquiring or transmitting HIV. The rates of gonorrhea and syphilis are higher among women of color than among white women. Socioeconomic issues associated with poverty include there may be limited access to high-quality health care, and they may exchange sex for drugs, money, or to meet other needs. There are much higher levels of substance use. Women accounted for more than 25% of the estimated 34,000+ AIDS diagnoses in 2009. This represents nearly 20% of cumulative AIDS diagnoses, including children in the US. There were 8,000+, almost 9,000 AIDS diagnoses among women in 2009, compared with 9,000+ AIDS diagnosis among women in 2006. In the United States, 27% of adults and adolescents living with HIV or AIDS in 2005 were women. About 6,000 to 7,000 of these women with HIV give birth each year. Women can pass HIV to their babies during pregnancy, while the baby's being delivered, or through breastfeeding. Mother-to-child transmission is the most common way children become infected with HIV. Nearly all AIDS cases in U.S. children are because of mother-to-child transmission. There's now regular testing of pregnant women for HIV and providing the antiretroviral drugs if they're infected, and that's dramatically reduced the number of children born with HIV. In 2005, only 57 children developed AIDS, a decline of 93% from 1992 when 855 children in the US developed AIDS. Without treatment or breastfeeding, about 25% of pregnant women with HIV will transmit the virus to their babies. A group of drugs, again, antiretrovirals, work well in stopping HIV transmission. If the women will take these drugs before, during birth, and their babies are given drugs after birth, they do not breastfeed, then HIV transmission is reduced from 25% to less than 2%, which works out to fewer than 2 in 100. It's a dramatic increase from when this first started. The women with HIV are living longer and healthier lives, and they can continue to take care of themselves and their children if they will continue with their regimen. Children with HIV, from the beginning of the epidemic, 8,000 plus children got HIV from their mothers, and they've been diagnosed with AIDS. Nearly 5,000 of those children have died. New cases of AIDS in children have steadily declined. And like their mothers, those children born with HIV are also benefiting from early diagnosis and better treatment. Young males who have sex with men, especially those of minority races and ethnicities, are at increased risk for HIV. In 2009, young males accounted for 27% of new HIV infections in the U.S. In 2008, an estimated 22% of persons aged 13 to 24 living with diagnosed HIV infection were infected through hemophilia, blood transfusion, birth, or unknown transmission mode, with the majority being infected perinatally. Antiretroviral therapy, or as I mentioned earlier, ART, A-R-T. And it's the recommended treatment for HIV infection. One of the complicating factors for patients on ART is it's a combination of 3 or more anti-HIV medications daily, and you have to take them right all day long, 24 hours a day. This ART prevents HIV from multiplying, destroying infection-fighting CD4 cells. So certainly this is why we emphasize that folks continue with the regimen and that will help protect them. The highly active antiretroviral therapy combines 6 classes of agents. I'm going to read these and you can see why we abbreviate it. First one's nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, fusion inhibitors, integrase inhibitors, and chemokine receptor 5 antagonists. These drugs were initiated in 1995 in the United States, and they've dramatically decreased HIV-related morbidity and mortality. The prevention of opportunistic infections is something that, again, HART can be used to work with preventing treatment of opportunistic infections. The guidelines, again, are provided by CDC, National Institutes of Health, and the Infectious Disease Society of America. And this tells you where if you want to go for more information. I want to talk lastly about HIV/AIDS in Florida. HIV cases by Florida statute, confirmed positive HIV tests must be reported to Florida Department of Health by every lab, as well as all people who diagnose or treat a person with HIV. AIDS cases, again, all persons who diagnose or treat AIDS case must report it to the Florida Department of Health, and that started early on in 1983. Approximately 90% of all diagnosed HIV cases and AIDS cases are reported at this point in time. People living with HIV/AIDS at a given time are also a reported case. Florida supports routine testing. However, requirements between public and private sectors are somewhat different. Informed consent is required for all HIV testing, both public and private, except for pregnant women who are tested unless they opt out, which I went over last time. In the private sector, there are certain things that are required to be told to the patient, and we're going to move on through this. There's some of these we've talked about before. If you need more time, you can stop this slide. The public sector, the statute requires that we provide the opportunity for pre- and post-test counseling. People living with HIV/AIDS, again, white, black, Hispanic, 2% other reported cases. Remember I talked about prevalence and incidence? Again, those figures. AIDS in Florida, we have a population of 18.8 million. We have the largest population, the fourth largest in the nation. And our population is 60% white, 16% black, 21% Hispanic, and 3% other. We are third in the number of cumulative AIDS cases, and that has always been true since we first started reporting AIDS in 1982. Cumulative pediatric AIDS, again, we're second in the nation. The death due to HIV/AIDS in Florida is 1,232 as of 2009, the latest time that figures are available. And this figure also goes into some detail about new HIV/AIDS diagnoses. In 2010 comes from the Bureau of HIV/AIDS, the Florida Department of Health. Again, I'm going to move on. Just the last couple ones, 25% lived in Miami-Dade County, 17% in Broward County. Some of the underlying factors for disparities: there's pre-existing HIV in the community, there's unprotected anal or vaginal intercourse between serodiscordant or untested partners, there are multiple partners, concurrent partners, late diagnosis and treatment, homophobia, and stigma, discrimination, and racism. Again, these are some of the things that I've mentioned earlier that are some of the underlying factors for disparities. Looking at HIV/AIDS cases in Florida, 95,000 are alive and known to be still living with HIV/AIDS, 70% male, 49% black, 20% Hispanic, and then of course the ages are listed there. In perinatal testing, it's very important, even if the patient has had no prenatal care or has refused testing until labor and delivery, rapid tests can be done at that time. Antiretroviral therapy can be started, and once it's begun intrapartum, rate of transmission is reduced to 10%. The prenatal HIV transmission rates are 2% or less when the antiretroviral therapy is initiated, adhered to during pregnancy. As you can see, this is why it's so critical that we test women and explain to them the possibility of their baby being born HIV infected. When the women receive no preventive treatment, the figure is 25% that perinatal HIV transmission will occur. When antiretroviral therapy begun intrapartum, rate of transmission is 10%. And then we have those babies born with AIDS in Florida. Florida ranks second behind New York on the number of perinatally acquired HIV infections born in 2009. We had 9, New York had 10. The number of perinatally acquired HIV infected babies born in Florida has steadily declined from 110 born in 1993 to 6 in 2010. Again, that goes along with antiretroviral therapy being developed and used. Of the 570 babies known to be born to an HIV-infected mother in Florida, 6 of those were known to be infected. Of these 6 babies, 4 mothers knew their HIV status prior to birth. 2 mothers found out after birth. Some of the risk factors, again, include inadequate prenatal care, no prenatal antiretroviral therapies, no ART at delivery, and no neonatal antiretroviral therapy within the first 6 weeks of the infant's life. And another risk is breastfeeding. Of those 6 perinatally HIV-infected babies born in 2010 that I mentioned, 1 of them was breastfed. Pediatric cases are defined as acquiring HIV prior to age 13. And I'm looking through that, some other statistics that go with pediatric HIV in Florida that you can spend more time with if you would like. The other area that I want to speak to briefly is the older adults, people age 50 and older, and they account for 50% of new HIV/AIDS diagnoses. People over the age of 50 have many of the same risk factors for HIV infection that younger people have. Many older people are sexually active but may not be practicing safer sex to reduce their risk for HIV infection. Older women may be especially at risk because of age-related vaginal thinning and dryness. It can cause tears in the vaginal area. Some people also inject drugs or smoke crack cocaine, which again puts them at risk. In HIV transmission through injection drug use accounts for more than 16% of AIDS cases among people age 50 and older. Some older people, of course, may be less knowledgeable about HIV/AIDS, so they're less likely to protect themselves. Many don't perceive themselves at risk for HIV, don't use condoms, and certainly don't get tested for HIV. Healthcare professionals also have a role in this. They may underestimate the older patient's risk for HIV/AIDS, and they may not deliver prevention messages, offer HIV testing, or make an early diagnosis that could help their patients get early care. Physicians may miss a diagnosis of AIDS in the older adult because of some of the normal aging symptoms like fatigue, weight loss, and mental confusion. Early diagnosis, which leads to prescription of antiretroviral therapy and other medical social services, certainly can improve a person's chances of living a longer and healthier life. Older persons in minority races, ethnicities, also can face similar discrimination and stigma that can lead to later testing, diagnosis, and reluctance to seek services. Some of the approaches that need to be developed for older persons who are at risk for HIV includes education to help them understand and be aware of HIV, skills training, help them negotiate risk reduction behaviors, messages that are age appropriate, culturally sensitive, and intervention strategies to help older women negotiate safer sexual behavior. And this talks a little bit again about the people with HIV who would develop AIDS was very high prior to 1996, and then once ART was available, it's dramatically changed the time between HIV infection and progression to AIDS. We must remember that medical treatments can prevent or cure some of the illnesses associated with AIDS, like those opportunistic infections, but there is not a treatment that cures AIDS at this time. And this talks about some of the studies that still continue to need to be done. And just a brief word about the AIDS vaccine, because they're working to develop preventive vaccines to protect people from contracting HIV, and therapeutic vaccines to boost immune response and control existing HIV infection. But none of this is currently available. There's no vaccine effective in preventing HIV. And this gives you a list of resources that are good in terms of looking for additional information. And that concludes this presentation about HIV and AIDS. Thank you for your attention. And oh my, time flies when we're having fun. Thank you again.